I'm super excited to bring an interview to you today with Dr. Julie Taguchi. Dr. Julie Taguchi is a renowned hematology oncology specialist specializing in breast cancer. With a profound understanding of estrogen significance in women post-breast cancer treatment, she has dedicated her career to enhancing patient outcomes and quality of life. She's the co-author of the book Sex Lies of Menopause and the principal investigator in physiologic restoration studies. Dr. Taguchi's expertise is sought after globally. Her commitment to compassionate care and groundbreaking research continues to shape the landscape of both oncology and hormone therapy. So in the interview today, I ask her some questions, some very hard questions around specifically breast cancer, estrogen, progesterone, family history of breast cancer, or other estrogen-sensitive cancers, and what is the real risk-benefit around taking hormones in certain situations, especially for someone with osteoporosis. So if this is a topic that you're interested in, this is an interview that you need to watch. All right, Dr. Julie Taguchi, thank you so much for your time. I have so many questions I want to ask you, and we'll try to keep this short for those that are listening and watching, but thank you so much for joining me on the Dr. Doug Show.
It's a pleasure. Thank you for having me.
Yeah, absolutely. So I think out of the gate, I would love to just give our viewers and listeners a little bit of background on who you are, what type of practice you've been in, and then kind of transition into where you are now, or maybe just tell us, how you were trained and what your training is. So let's maybe just start there.
Okay, well, I have been trained as a hematology oncologist. So I practiced medical oncology, hematology in Santa Barbara for about 30 years, basically focusing on breast cancer health. I was the only woman in the oncology department, so I attracted a lot of, obviously, women with breast cancer and GYN cancers. So I just became very knowledgeable in that area and specialized in that. Then in, I believe in the late 90s, I was introduced to T.S. Wiley, who basically she's the one who introduced me to compounded hormones and rhythmic dosing. And if I need to explain that, I'm happy to do that.
Yeah, our audience probably knows what that means, and we can get into that later, but let's just keep on with your story for now.
Okay. Rhythmic dosing. And what I realized, my patient population, as part of the treatment for breast cancer, particularly for ER-positive breast cancer, is that we castrate women. And it sounds like a terrible word, but that's what we do when we give tamoxifen, and particularly the aromatase inhibitors, or we call those the AIs. Women would have all kinds of side effects from not having estrogen. And that could be not sleeping, the brain fog, the joint pain, irritability, depression, not to mention no libido, dry vagina, dry everything else. And so women would question, like, why am I like this? What's happening to me? And of course, they said, this is what happens when you get treated for breast cancer. People didn't like that, and they said, I don't understand it. And I said, it's because of estrogen. You don't have estrogen. This is what happens. And they said, oh, I don't want to live like this. And so therefore, I became the only person, their lifeline to hormones, because there wasn't any other provider that was going to give them estrogen. And the only hormone replacement therapy I knew about was the rhythmic dosing, which used estradiol and progesterone, and not the drugs that were very popular at the time, which was Premarin and Prempro. And so I became very interested in that.
Yeah, and just to give our audience a little bit of understanding around the timeline of that. So when did you start treating women like this with rhythmic dosing, bioidentical hormones? What was the era?
For me, it was rapid. I would say I started in the year 2000.
Yeah.
Maybe 1999, something like that.
And so then you were practicing this way when the Women's Health Initiative came out in 2002 and then subsequently in 2004 publication. So I could only imagine what that was like. Yes,
thank you. Yes, we had that book, which was what I call the thesis for hormone replacement, right on the tails of the Women's Health Initiative that said, don't do hormones, they're going to kill you and give you breast cancer. So,
yeah. All right. So then, so fast forward now. So that was in early 2000s. Now we're in 2024. What is your practice like now?
So I left the medical oncology world, and I'm currently in solo practice in downtown Santa Barbara. I do a lot of education, and I help other practitioners or other providers explain to their patients, or explain to the patients and the providers sometimes, about the risks of hormone replacement with whatever complicated history they have, particularly breast cancer. So I do a lot of that. I have my own practice here in Santa Barbara. I do some oncology navigation and whatnot, but a lot of education too.
Yeah. Well, and that's so great because, you have literally decades of experience. You are actually an oncologist who specializes in breast cancer. So your perspective on the risks and benefits of hormones in the face of both breast cancer risk, breast cancer survival, family history of breast cancer, these are areas that I want to dig into today because we get these questions all the time, and there's so much fear around breast cancer for women, which is rightfully so. However, when we're deciding whether or not we're going to do something as an intervention like hormone replacement, then we really need to understand the risks and benefits and put numbers on it as best we can. So that's what I want to do today. Before we get into some of the specific things, though, can you just, because this is probably the most common comment, it's not even a question. This is a comment that I get, because I do a lot of content on estradiol and estrogen, and there is always multiple comments of, but estrogen causes breast cancer. So can you just address that from your perspective as a specialist in breast cancer? When someone says to you, but estrogen causes breast cancer, can you just tell me how you would discuss the actual risk with that person?
Yes. You should know, or women should know, that the average age of breast cancer is about 62 to 64. So and menopause is about 51. So there's about 10 plus years without hormones in the menopause era, when breast cancer is, most common in that age group at diagnosis. But the other thing is, too, there is a peak incidence of breast cancer diagnosis between like 45 and 55. When the hormones are sliding in the 40s and going down into menopause, then there's a spike of breast cancer diagnosis when there are no hormones. So that's one thing we have to look at, the biology. The Women's Health Initiative, they prove that if you took 6 years of oral Premarin, now mind you, that's the horse urine metabolite. If you take 6 years of that, then there was a significant reduction in breast cancer by 23%. So, and what was really great about that study was that that risk reduction held 20 years later. So I think
Right.
when they reported it a couple of years ago, that group was great. So, but it was only 6 years. That's what they said, 6 years of Premarin. But still, that's when the thinking changed. Oh, maybe estrogen doesn't cause cancer. So that was a big turnaround for medicine. For those who were paying attention, I should say, because there are people who don't pay attention now.
Absolutely. And another thing that I think is really important to remember in that 2002 publication, for those that most of my audience probably heard me talk about this too many times, but the 2002 publication was on the combined therapy, so the Prem-Pro therapy, and then the 2004 publication was on Premarin alone, right? And we saw that increased risk with Prem-Pro that actually also held up over time. And then the decreased risk with Premarin that eventually became statistically significant and continued to become, those two groups they got wider, right? One being protective and one being potentially associated with an increased risk of breast cancer. And so I've also looked at that. I mean, the numbers, this is true for men and prostate cancer too. And that's a whole other topic, but testosterone and prostate cancer, estrogen and breast cancer. And if you look at when women have the most estrogen, they have the lowest risk of developing cancer. It's not even a logical hypothesis that we would want to explore. It just popped up because of something else. So I wanted to ask you about then the role of progesterone in this, because I just mentioned that Prem-Pro, obviously the pro part being the synthetic progesterone. What's your interpretation of the data there, and the role of progesterone versus progestins in hormone therapy?
Oh my gosh. So the Women's Health Initiative, they used Prem-Pro, which is daily Premarin and Provera, or daily, it's conjugated equine estrogen and progestin. Okay, these are drugs with hormone effects. Now, mind you, the Premarin or CE comes from a horse, so that's the natural component of it, but we're not horses. So there's some kind of a conflict there. So this was, this combination of the Premarin and Provera was given on a daily basis, and this is not a natural pattern for hormones in the first place. And progestins are not progesterone. They vary very differently in their molecular structure. Now, and the reasons why the progestins were even brought to market is one, these natural hormones like estradiol and progesterone cannot be patented, but their delivery systems can. The progestins were basically, modified, hormones made into a drug that they could patent and sell and deliver as an oral agent. The primary focus of that was to keep the uterine lining from proliferating into uterine cancer. So unopposed estrogen every day, right, all the time, without progesterone, there is an increased risk of uterine cancer. So that's why the progestins were made. I can't stand the progestins. I don't even know why they're still in on the market, except for maybe some emergency bleeding issues for GYN.
Yeah.
I
forget what the actual market share is, but even of Provera, even of NPA, medroxyprogesterone acetate, it's not small. It still has a considerable market share. And yet we have a 20-year follow-up study demonstrating that it has an increased risk of breast cancer diagnosis. It's kind of really mind-blowing.
Can I address that for a second?
Yeah, go ahead.
So in that group, that group was, there were only like 8 more breast cancers than the placebo group, the placebo group.
Yeah.
And what they realized is within 5 years, maybe this Prem-Pro fostered the growth of pre-existing disease. So we know that breast cancers don't develop in a matter of years. It takes a much longer time for the most part. And then one thing about this population, the group who had breast cancer on those drugs, they actually are surviving a little bit better than those who were not. So their survival benefit right now nobody dies earlier than because of it. And they might even live longer because of it.
Yeah. Well, yeah. So let's dig in. Before we dig into that, there's one more thing I want to talk about before we dig into that, because we have so many women, especially in our who are listening to me, who have a diagnosis of osteoporosis. They have either a family history, a personal history. So I want to dig into the personal history in a minute, but let's talk about the family history first, because this is something that I see misinterpreted by so many physicians, OBGYNs, anybody else who's willing to prescribe hormones. They have a very strong opinion on the family history thing. And so many women think that if they have a family history, they are not candidates for hormone replacement therapy. So can you just give us a summary of your perspective on the research around the family history of if a woman has an immediate family member with a breast cancer history? How do you look at that? And then how do you counsel patients on that?
So it's a good question. I have a whole list of things that I can ask about breast cancer risks in general. And so the family history is clearly one of them. If your mother and your sister, have breast cancer diagnosis, you as the other sister, your risk goes up exponentially. So that's important, but that risk is already inherent. That person has the risk, okay? If you add hormone replacement therapy to somebody with that kind of a high risk, I'm going to call it 4, a risk of 4 times normal, okay? And the breast cancer risk with hormone has been set at 1.2 or I'm going to call it a 1 to 2. But your inherent risk of having breast cancer because of the genetics and family history is already higher. Adding hormone replacement to that has no effect on making that risk worse. And so I tell people it doesn't really matter. It does not matter, but it matters to you individually on your own health. And so if they're at risk for heart disease, dementia, they have an APO4 gene, it's something to look at as well. There are women who they get to the 51 menopause and they go, I want to be on hormone replacement because of my family history. I go, well, you just lived the last 40 years on hormones until you got to menopause. So you don't have it.
Yeah. And so then the next question that comes out of this is, I have this family history, but I have osteoporosis. I don't want to start hormones because I'm concerned that I'm going to develop breast cancer. And then I walk patients down this pathway, which is, okay, let's talk about that. if you're on estradiol specifically, and you're on micronized progesterone, and you develop breast cancer, what are the differences for a woman who's on an optimal form of hormone replacement therapy versus placebo or non-user in the face of developing breast cancer?
So let me clarify your question. So if they're
Sure.
on the micronized cyclical, it doesn't matter. But they're on
Either way,
estradiol.
pick, yeah. Mm-hmm.
So at this point in time, there is no the research with those hormones, the real hormones, does not have. There's no increased risk of breast cancer on the studies that we have right now. So
Yeah.
we don't have 8,000 women versus a placebo, but
Right.
everything that we can pull together does not show that there's an increased risk with that.
And what about the survivability or the specifics of the cancer, like grade of cancer? Is there a difference in women that are on therapy versus not, in your experience?
Yes. So I would say women who've had the triple negative breast cancer, I've been treating them for 25 years. No problem, because now it was logical. Women who have triple negative disease, we don't put them on tamoxifen or AAs because it doesn't work. So why not put them on hormone replacement, right? But the standard of care was always never do hormone replacement in any breast cancer population. So anyway, but I will tell you, all my triple negative patients, or women with triple negative disease, are all alive on rhythmic dosing, decades later.
Yeah.
And then women with DCIS, man, I have data in my own population. Those women don't recur. They don't have a problem. I mean, as long as they are treated with the standard of care, so with a lumpectomy, most likely radiation therapy, or mastectomy if they choose that, they're total candidates as far as I'm concerned. They have no problem.
Yeah.
And then as you go into the higher stages, it's going to be, well, I used the oncotype score. What were they treated with? And we have the conversation. It gets a little more complex.
Yeah. Yeah. And it's definitely a difficult conversation for mine because I'm not an oncologist. And we try to get oncology involved. But as you said, the standard of care and most oncologists are not interested in having that conversation. One of the things that I've leaned on in the literature for women that are at, in theory, higher risk, maybe because of family history, is that my understanding of the literature is that there is a difference in the type of cancers that generally develop for women that are on hormone replacement therapy versus not, as well as survivability, and that it favors being on hormone replacement therapy at the time of diagnosis. Is that consistent with what you've seen?
Yes. Yes, it is actually in clinic. And it's something I didn't pick up until I read it in the literature. But I have all these women who've been living for a while. And even there's been a few they had, like, I call it stage 2B, grade 3. They are high risk, node positive breast cancer. They had mastectomies, chemotherapy, maybe a year of some aromatase inhibitor till they realized they couldn't live like that. And I put them on rhythmic dosing. One person lived 15 years. She became a ballroom dancer after coming out of, she was she was bedridden from the AIs, became a ballroom dancer. Anyway, she lived 15 years with great quality of life. She had a recurrence after her third spinal surgery in the same place, and that's where her recurrence was. So that made me think that the surgery was the stimulus for the recurrence in the bone right there. So anyway, and she lived on hormones and stayed on hormones through her treatment because she said didn't matter to her. She was going to keep that quality of life.
Yeah, well, that's a great segue. So let's talk about that. So let me just actually summarize. So for people that have a family history and are at risk, I mean, my summary of the literature, when I dug into this with my team, because we were trying to come up with we just needed a plan for all the patients that are coming in with this family history concern. And my consensus was you could easily make an argument with the literature that actually, if you're at high risk, you're actually better off on hormones if you have a reason to be on them.
Interesting.
Right. And so it's we don't make that stance, and that's not our stance in our practice, but you could easily make that argument based off of the literature. So it then makes that conversation easier for women that have that concern, because we can say, look, you could go as far as this, but let's stop here because this is where we're comfortable. And it's just been a really great way to look at it. And of course, we don't put all women on hormones that have a strong family history, because it's like you said, it's their concern, so let's talk about what's right for you. So, okay, let's get into treatment. So a woman gets diagnosed with breast cancer, and there are so many different ways that you can get a diagnosis of breast cancer. But there are women who maintain, especially rhythmic hormone therapy, because they're in a different kind of population of doctors. But women that are staying on hormone replacement therapy in the face of breast cancer, even if it's not triple negative. So can you walk me through how does that make sense? And when your patients were coming to you like this, and like this patient with a recurrence that stayed on hormone replacement therapy, can you walk me through the logic behind that? Because this is an area where I don't have experience clinically, but clearly you do.
So it's not common. It's few women who do that, because a lot of people get fearful when they have the relapse, right? And our first line therapy for breast cancer is basically castration for ER positive disease, and then it's called the anti-hormone drugs, and a second agent now, which is a CDK4 inhibitor. I don't know if you've heard these names, Ibrance, palbociclib, and Verzenio. So we use doublets now for treating first-line metastatic disease. So you can't really give an AI or hormones with an aromatase inhibitor, okay? Because the estrogen will bypass the AI. But you can give hormones with tamoxifen, okay? So just because we give tamoxifen for premenopausal women, and they have lots of estrogen floating around, and so the tamoxifen blocks that. So there are women who are postmenopausal with hormone receptor positive disease on tamoxifen, and they have extra estrogen on board, and it does help mitigate their symptoms. But we have data to support that, about the HABITS trial and the Stockholm.
Mm-hmm.
Oh, yeah.
Mm-hmm.
So,
yeah.
So they have these trials. Now, mind you, it's a trial that I would have never done, because I used oral tamoxifen and 2 milligrams of oral estradiol.
Yeah.
And that's a lot of oral estrogen, and there was no clotting incident, which surprised me.
Right.
And the HABITS trial stopped early because of an increased breast cancer risk. And the Stockholm trial continued because they didn't, but there was a difference. And the difference was the progestin. The HABITS they had daily progestins in that trial, whereas the Stockholm trial had they cycled it every 3 months. So they had less progestin exposure.
Yeah. And didn't the difference between those two trials, it's been a while since I looked at them, but in the HABITS trial, didn't they also not screen before onboarding patients for breast cancer? In other words, we don't know if they had anything going into it.
No, they were breast cancer patients.
Oh, they were breast cancer patients. All right, I'm mixing them up.
Sorry, I didn't. I think I flipped over to the women with breast cancer treated with.
Got it.
And the reason for that, and I was getting to the data for those trials because I had postmenopausal women on tamoxifen and hormones.
Got it. Right. And so, and this is what I was recently listening to a speaker talk about tamoxifen, and she was actually speaking about the same thing. And tamoxifen is not a complete estrogen receptor blocker, right? So you still get benefit of being on estrogen, but yet there are not probably very many doctors who would do that, or who would recommend that.
But you're back to comfortable with risk, quality of life.
Yeah.
I mean.
And let's talk about the risk. So tamoxifen is a very popular drug to use after whatever surgical intervention, potentially radiation, right? Women are recommended to take tamoxifen. Can you talk a little bit about what is the actual risk reduction of recurrence with tamoxifen or AI if they're similar?
Well, it depends on the disease status. Okay, so if you're ER positive stage 1, there's something I have to go back and let you know. There's a tool that we use called the Oncotype DX. Are you familiar with that?
I've heard of it, but I don't know how to use it.
Okay, so it's a pathology test. They take the tumor and they look at 21 different genes within the tumor, They look at proliferation genes, K67, estrogen, progesterone receptor, HER2, et cetera, and several other genes. And there's a score. And if the score, higher the score, then we give chemotherapy. And the score, like the cutoff is usually 25, 26 or higher. We will recommend chemotherapy because we believe but from studies, there's a chemotherapy benefit for that group. Under 25, no, but hormone blockage, yes. So we use that data. And we also know that if the score is like less than 10, those women, if they're treated with their lumpectomy and radiation and or mastectomy, they have a very little, really less tiny risk of recurrence. So I use that tool to help discuss risk.
Gotcha. So then this becomes a challenging conversation, right? Because it's going to depend on their score is going to sort of dictate their recurrence risk. And so then when you look at the research on how beneficial tamoxifen is, what is the reduction in recurrence that occurs with the use of tamoxifen? How do you know? Because it's going to change, obviously, based on their risk of recurrence.
So the general rule of thumb, we say, there's a 50% reduction of a risk of relapse in those women who are going to relapse. So you have to know how many women are going to relapse. So if you say 30% are going to relapse, we could say tamoxifen or AI reduces it by half, 50%. So 100 women on, say, tamoxifen, and we know that 30% of them are going, or 30 of them are going to relapse. With the tamoxifen, 15 women will not relapse within that 10-year trial. And those 15 women will have a survival benefit. But it doesn't mean that doesn't happen. They still recur, but after the 10-year mark, 20, whatever, they just push out the relapse, okay? Because these drugs don't kill cancer. And then the other 15%, this is what's really important. People don't understand this. The other 50% that do relapse, there's a driver that we do not know what it is. We don't know what drives it. It's going to be something that could be like insulin. It could be there's several other factors that drive breast cancer. That's not estrogen. And so we always say there's a 50% reduction in those who are going to relapse when you use tamoxifen.
Yeah. And that's what's challenging about this drug, because that sounds like a great number. You're like, I want to take a drug that reduces my risk of relapse by 50%.
Yeah.
So then why don't we? You mentioned castration, but can you give us a sense of, how do these women feel on the drug? And I know it's variable, but in your experience, what do patients complain to you? Because otherwise, if it was easy, we would just use these drugs, but there's a downside.
Yeah.
So what's the downside?
For the aromatase inhibitors, 40% of the women go off of it because they can't tolerate it. So that's a big number. And oncology right now is trying to make it's a big push trying to keep women on the AIs. But anyway, because we medically castrate women with the aromatase inhibitors, because it basically prevents the conversion of testosterone or DHEA, the androgens, into the estrogens, which is the postmenopausal woman's estrogen source. So the aromatase inhibitors block that. And so every organ system is affected by not having estrogen. From the top of your head, your hair, to your toes, in terms of your bones and nails, your brain, your memory, your even your digestion is controlled by estrogen. Your microbiome has something called an estrobolome. So we know that postmenopausal women and premenopausal women, they have a different microbiome. And then women who have breast cancer who are postmenopausal and women who are just postmenopausal without breast cancer, they have a different microbiome. So there's a lot of information there. But, estrogen matters literally in every part of your body. I think estrogen receptors are everywhere except the red blood cell, maybe.
Yeah. And I think this is an interesting thing too, that I keep finding in the literature is that, the difference between quote unquote, losing estrogen as a woman through natural menopause versus surgical menopause versus chemical castration, as we're calling it, right? And, in natural menopause, women continue to make a little bit of estrone. It doesn't go down quite as quickly. It can still be absolutely symptomatic. I'm not saying it's not. But a surgical menopause where it's, the ovaries are removed, so obviously it stops suddenly, and you see a dramatic difference in how quickly women will have issues with osteoporosis, with cardiovascular risk, with dementia. Like all of those things happen so much faster in that group. But then when we talk about AI, and especially AI versus tamoxifen, where the AI drugs are more powerful, they're bigger blockers of the aromatase enzyme, it's going to be more like surgical menopause, where estrogen is just stopped at every cell, at every level, right? Am I saying that correctly?
Yes. And I would say yes, but we give AIs to women who are postmenopausal already, so they've kind of done the conversion. So, but surgical menopause for a premenopausal woman is catastrophic. and chemo, I call it chemopause for the oncology, premenopausal women getting chemotherapy, they can go into menopause. It's incredibly tough.
Yeah. Well, and I think it's really interesting when you, because I've heard this story, and I'm sure you've seen it much more than I have. When you take a postmenopausal woman who's not on hormone replacement therapy and you put her on, let's say, an AI, it's interesting that she is still so symptomatic because the body is still has a low level of estrogen. There's some estrone being produced, et cetera. So like take a woman who even technically doesn't have, quote unquote, any estrogen, because she does have some, and then put her on an AI and she feels very, very different, right?
Yep.
Yeah. So even though it's less, it's not none for our postmenopausal women.
No. They're definitely symptomatic. I didn't mean to go
Yeah,
there.
no. And you weren't suggesting that. I hear that from some women to say, well, I don't have any estrogen anyway, so why does it matter? It does matter. Yeah. So, all right. So then there's this drug that is causing a lot of symptoms, but it can reduce our recurrence or relapse, a better way to say that probably. We can reduce our relapse by 50%, which sounds great if you don't want to have cancer again, right? But yeah, there's a lot of women who are coming off of this drug and some women who are refusing to take it in the first place. Now that I've been in this space for a while, there are some drugs that just create, in like the social media space, there's just like a hatred towards some of these drugs, and like statins are certainly in that group. And I think tamoxifen is sort of in there as well, where there's just like a cultural bias against this drug. What for women that are trying not to take it, what is their, or if they're going to go on hormone replacement therapy and refuse to take it rather than take them together, do you have women that have gone down that pathway, and do you counsel women on that? Because I've been asked to counsel women on this, and it's a challenging conversation.
Oh, absolutely. Every woman I counsel who has breast cancer, a personal history of breast cancer or breast cancer, I have to bring up the fact that metastatic disease is a possibility because they have the original diagnosis. And I go through, okay, if you're not going to take finish your 5 years of tamoxifen or AI, and you have a metastatic relapse at year 7, how would you feel about that? And that answer tells me everything about that patient. So either I was very good at explaining their risk and what can happen and blah, blah, blah. And they'll say, it doesn't matter. I'll have 7 years of great life. And this was going to happen anyway. And maybe it happened a little faster, but, and then the game changes. We have to castrate them at that time if they're going to be treated. They're willing to accept that treatment for that, that stage because they know they're doing something versus they're not sure they're doing. We overtreat with the anti-estrogen therapies, as I told you about, for stage 1. Yeah. 70 women are getting a drug 85 women are getting a drug that's not going to help them.
Yeah. So let's say that again. So for stage 1, we'll just tell people what stage 1 means, I guess. Let's start there.
Okay, thank you. Stage 1 breast cancer would be something that's 2 centimeters or less and node negative. So it's, that's our old staging category. And so if you put all stage 1 breast cancers in that group that are estrogen receptor positive, we say that there's about a 30% relapse, even with a stage 1 early stage breast cancer within about 10 years. Now, mind you, within that subset, there's a lot of variation. And as I said, the tumor genetics matter. Within that stage 1, there's going to be low risk stage 1, high risk stage 1. Okay. And that's why we'll give chemotherapy even to a high risk if it's really high. So there's 30% that will relapse in the 10-year period of time.
Yeah.
All of them are going to be all of them will be recommended to have tamoxifen or aromatase inhibitor. All of them. So 100 women will get this drug, but we know that maybe half of them of the 30 that are going to relapse, so 30 to 15, only 15 women are going to benefit from that drug.
Yeah.
And the rest of them, they didn't need it. Surgery or radiation helped them, the local therapy, or they had low, risk. And then the other 15 that do relapse, tamoxifen, estrogen wasn't the driver. It wasn't driving the tumor. Something else was, and we don't know what that is.
Right. Yeah. And so then can we go back another step? Because we have a lot of women who have had, let's call it stage 0. Can you maybe explain stage 0 DCIS and give us the difference there for the same situation?
Yes. DCIS is, some people say, it's not cancer, but they are cancer cells. They're clearly malignant cells, but they're contained in their little duct from what we can tell on a pathology slide. So there's high risk and low risk DCIS as well. And the concern about DCIS is that even if you remove it, there's a risk of it coming back as invasive breast cancer. And so that's why they like to do the, say the lumpectomy, or could be mastectomy if it's a large DCIS area, and radiation, just to reduce that risk of a invasive breast cancer. Basically means those malignant cells are outside the duct, or they're not associated with the duct. And so it's a different kind of a disease. And usually there's a lot of older women who have DCIS and they die with DCIS and not with active breast cancer. So it can be a very indolent process. But those women who have it and are treated, and I say, in terms of treatment, appropriately treated on hormone, I think those women are candidates for hormone replacement. The risk of having recurrence is essentially nil, but their risk of having everything else is up here.
Yeah. And are those women recommended to use tamoxifen or AI if they've had, they are.
Mostly for the, mostly for the contralateral breast, right? As well, they can reduce activity. What happens too, again, it might suppress a tumor that's already being formed in the breast, for instance, but once you're off the tamoxifen, it can recur later. So.
Yeah. And do you have numbers on that group, the DCIS group, off the top of your head?
That does what?
Recurrence and the benefit of tamoxifen if it's 50%.
Okay, so the way it kind of goes is there's about a 50% risk of recurrence if you have surgery alone. Then if you have the radiation after that, it might drop it down to like 4%, and then the drugs add another 2%.
So then say that again. So 50% risk of recurrence with surgery alone, and that would be lumpectomy alone?
15%.
Oh, 15. Okay. Oof, that's a big difference. So 15% recurrence after lumpectomy alone?
Yes.
And then RADS drops it to 4, and then AI or tamoxifen drops it to 2.
Yeah.
Yeah. 2 sounds good.
Yeah,
but 4 is not bad.
Right. No, 2 to 4. 2 to 4 range. Yeah.
Yeah. And then mastectomy versus lumpectomy, interesting difference there, right? Yeah. Or does it not change?
It does change because we don't advise any adjuvant hormones because there's nothing there. But
there's no tissue left.
Except for the other breast, you can do contralateral risk reduction if it's.
Gotcha. Yeah. Yeah. Okay. Well, that's really helpful. I know people ask me numbers all the time, and I don't know all the studies. I only know the studies that I've seen. So that was really helpful. Gosh, we've been going over 30 minutes, I think already, haven't we? Where am I? Yes, almost 40 minutes. All right. I think let's call this today. And I think we probably need to do a part 2, and there's so many things I want to discuss. But let's just call it today. I think that was hopefully really helpful for women that are having this conversation with their doctors and with their family. Can you just close this out for us and just hopefully to give some women a little bit of hope, let them can you just give them what would you like to say to all the women that are struggling with this conversation, with this diagnosis, who are considering hormone replacement therapy? Can you give them some hope that, that all is not lost here?
Yes, I can, because, the literature too does not really promote that hormone replacement is an absolute no. So it's like, if you give hormone replacement, women are not blowing up with disease. It just doesn't happen. So it's more of a fear-based thing and a theoretical issue. So hormone replacement is not completely contraindicated. You have to go on an individual basis, your family history of other diseases, your own personal history of other diseases, personal ownership of what you want for your health.
Yeah. Okay. Yeah. And I think in our population of women with osteoporosis, that conversation changes again. And it becomes more challenging because the risk of hip fracture, the risk of other fractures, the risk is higher probably than recurrence, depending on the situation. So challenging conversation. Thank you, Julie, for all of your expertise in this space. Like I said, we'll have to do a part 2 sometime, and there's some other things I want to talk about, especially getting into static versus rhythmic dosing. I think that's probably a whole conversation in and of itself.
Yeah. Thank you so much. Appreciate it.
Awesome. Thank you. All right, I hope you enjoyed that interview with Dr. Taguchi. This is a really challenging area and a challenging topic of discussion. If you want to reach out to Dr. Taguchi, her website for her clinic is in the description on YouTube, and it'll be in the show notes for the podcast. She does see patients. She has a small practice out in California, but she does also do quite a bit of educating and things outside of the medical arena. Please reach out to her if you need to. Additionally, if you're interested in a community of people who are talking about their bone health, talking about hormone health, asking questions to other people that are going through this with osteoporosis, consider joining our Osteo Collective. The Osteo Collective is our community of individuals with osteoporosis who are trying to do this on their own. We're providing them the tools through the community. We have a weekly topic-driven Zoom Q&A that is now internationally viewed, and so many resources to consider. So if you're looking for a community, we've got a great community called the Osteo Collective. You can look for a link for that in the description as well, or in the show notes on the podcast. See you in the next video.